Question 1. The control framework reveals a hemodialysis patient reporting persistent and significant thirst, despite adhering to their prescribed interdialytic fluid allowance. The registered dietitian nutritionist (RDN) is tasked with evaluating and potentially adjusting the fluid management plan. Which of the following represents the most appropriate initial approach for the RDN? Option A. Advise the patient to simply drink more water between dialysis sessions, as thirst is a subjective symptom that should be managed by the patient's own discretion. Option B. Conduct a thorough assessment of the patient's interdialytic weight gain, blood pressure readings, presence of edema, and review recent laboratory values, while also exploring potential non-fluid-related causes of thirst, and then consult with the nephrology team to discuss findings and propose adjustments. Option C. Immediately increase the patient's prescribed fluid allowance by 250 ml to alleviate their reported thirst, assuming the current restriction is too stringent. Option D. Maintain the current fluid restriction without modification, as adherence to the prescribed allowance is the primary goal, and thirst is a common, unavoidable symptom in CKD patients. The correct answer is B. Conduct a thorough assessment of the patient's interdialytic weight gain, blood pressure readings, presence of edema, and review recent laboratory values, while also exploring potential non-fluid-related causes of thirst, and then consult with the nephrology team to discuss findings and propose adjustments. Explanation: this scenario is professionally challenging because it requires balancing a patient's subjective experience of thirst with objective clinical indicators of fluid overload, all within the strict confines of renal nutrition guidelines. The registered dietitian nutritionist, RDN, must interpret complex patient data, consider individual patient factors, and apply evidence-based practices to ensure patient safety and optimize outcomes, while adhering to the specific regulatory framework governing renal nutrition. The correct approach represents best professional practice because it prioritizes a comprehensive, individualized assessment that integrates multiple data points. This includes not only the patient's reported thirst, but also objective measures like interdialytic weight gain, blood pressure, edema, and laboratory values. By systematically evaluating these factors and consulting with the nephrology team, the RDN ensures that fluid management strategies are tailored to the patient's current physiological state and risk factors, aligning with the ethical imperative to provide competent and safe patient care, as outlined by the CSR credentialing body's standards of practice. This approach also reflects the regulatory emphasis on patient-centered care and the need for interdisciplinary collaboration in managing complex chronic conditions like CKD. An incorrect approach that relies solely on the patient's reported thirst without considering objective clinical data fails to uphold professional standards. This could lead to inappropriate fluid prescription, potentially exacerbating fluid overload and its associated complications, e.g., hypertension, pulmonary edema, which is a direct violation of the duty to provide safe and effective care. Ethically, it demonstrates a lack of due diligence in assessing the patient's overall condition. Another incorrect approach that involves unilaterally increasing fluid allowance based on subjective complaints without consulting the nephrology team disregards the critical interdisciplinary nature of CKD management. Fluid management in dialysis patients is a delicate balance that requires the expertise of both the RDN and the nephrologist. Failing to collaborate can lead to conflicting treatment plans and adverse patient outcomes, violating ethical principles of teamwork and potentially contravening regulatory requirements for coordinated care. A third incorrect approach that involves rigidly adhering to a preset fluid restriction without reassessment, despite evidence of significant thirst and potential dehydration, also represents a failure in professional judgment. While guidelines provide a framework, they must be applied flexibly based on individual patient response and evolving clinical status. This rigidity can lead to patient discomfort and potentially compromise nutritional status or other aspects of care, demonstrating a lack of adaptability and patient-centeredness. The professional decision-making process for similar situations should involve a systematic approach. 1. Gather comprehensive data. Collect all relevant subjective thirst, diet, and objective weight (BP, edema, labs information. 2. Analyze data in context. Interpret findings considering the patient's CKD stage, dialysis modality, comorbidities, and medications. 3. Identify potential causes. Determine if thirst is due to appropriate fluid restriction, dehydration, or other factors, e.g., hyperglycemia, certain medications. 4. Consult and collaborate. Discuss findings and potential adjustments with the nephrology team. 5. Develop an individualized plan. Propose fluid management strategies that balance patient comfort with clinical necessity based on evidence and team consensus. 6. Monitor and reassess. Continuously evaluate the effectiveness of the plan and make necessary adjustments. Question 2. Process analysis reveals a 72-year-old male patient with stage 4 chronic kidney disease, CKD, presents with significant fatigue, unintentional weight loss over the past 6 months, and subjective muscle weakness. Laboratory values show a stable glomerular filtration rate, GFR, but elevated BUN and creatinine. The patient reports a poor appetite and has been consuming approximately 0.6 grams of protein per kilogram of body weight daily, primarily from plant-based sources. He expresses concern about his declining strength and its impact on his daily activities. Considering the patient's presentation of potential protein energy wasting PEW in the context of his CKD stage, which of the following nutritional management strategies would be most appropriate? Option A. Recommend a significant increase in protein intake to 1.2 grams per kilogram of body weight, utilizing a variety of protein sources including those with lower biological value. Option B. Advise the patient to continue with his current dietary pattern, as protein restriction is paramount in all stages of CKD to prevent further kidney damage. Option C. Increase daily protein intake to 0.8-1.0 grams per kilogram of body weight, emphasizing high biological value protein sources while ensuring adequate caloric intake. Option D. Maintain current protein intake of 0.6 grams per kilogram of body weight and focus solely on increasing caloric intake from non-protein sources. The correct answer is C. Increase daily protein intake to 0.8-1.0 grams per kilogram of body weight, emphasizing high biological value protein sources while ensuring adequate caloric intake. Explanation. Scenario analysis. This case presents a common yet complex challenge in renal nutrition management. Optimizing protein intake for a patient with advanced chronic kidney disease, CKD, who is not yet on dialysis but exhibits signs of protein energy wasting, PEW. The challenge lies in balancing the need to preserve lean body mass and mitigate PEW with the established recommendations for protein restriction in CKD to slow disease progression. The patient's subjective complaints of fatigue and muscle weakness, coupled with objective findings, necessitate a nuanced approach that moves beyond a one-size-fits-all recommendation. The registered dietitian nutritionist, RDN, must consider the patient's specific stage of CKD, the presence of PEW, and the potential impact of different protein strategies on both nutritional status and kidney function, all within the framework of current evidence-based guidelines for renal nutrition. Correct approach analysis. The most appropriate approach involves a comprehensive assessment of the patient's PEW, including anthropometric measurements, biochemical markers, though these can be confounded in CKD, and functional status. Based on this assessment, the RDN should implement a strategy that carefully increases protein intake, focusing on high biological value HBV protein sources, while simultaneously addressing energy needs. This aligns with current understanding that in the presence of PEW, a moderate increase in protein, particularly HBV protein, can be beneficial for muscle synthesis and overall nutritional status in pre-dialysis CKD patients, without necessarily accelerating CKD progression if managed appropriately. This approach prioritizes the patient's quality of life and functional capacity, which are significantly impacted by PEW, and is supported by evidence suggesting that aggressive protein restriction can exacerbate PEW. The focus on HBV protein is critical as it provides essential amino acids more efficiently, minimizing nitrogenous waste. Incorrect approaches analysis. One incorrect approach would be to maintain strict protein restriction without addressing the PEW. This fails to acknowledge the detrimental effects of PEW on patient outcomes, including increased morbidity and mortality, and overlooks the potential benefits of a carefully managed protein increase in this specific context. Ethically, it could be considered a failure to provide optimal nutritional care when evidence suggests a different course of action is warranted. Another incorrect approach would be to significantly increase protein intake without considering protein quality or energy intake. This could lead to an excessive nitrogen load, potentially worsening uremia and accelerating CKD progression, without effectively addressing the underlying causes of PEW if energy needs are not met. This approach lacks the necessary specificity and targeted intervention required for complex renal nutrition management. A third incorrect approach would be to recommend a high intake of low biological value (LBV) proteins, while increasing protein. This strategy would be less effective in promoting protein synthesis due to a less favorable amino acid profile and would generate more metabolic waste, potentially exacerbating uremic symptoms and placing a greater burden on the kidneys. This demonstrates a misunderstanding of protein quality's importance in renal nutrition. Professional reasoning. When faced with a patient exhibiting PW and advanced CKD, the RDN must move beyond generalized recommendations. The decision-making process should involve 1. Thoroughly assessing the extent and contributing factors of PW. 2. Evaluating the patient's current protein and energy intake against estimated needs, considering the stage of CKD. 3. Consulting current evidence-based guidelines for renal nutrition, which often differentiate recommendations based on the presence of PW and the patient's clinical status, pre-dialysis vs. dialysis vs. transplant. 4. Developing a personalized nutrition intervention plan that prioritizes HBV protein sources and adequate energy intake to combat PEW, while monitoring kidney function and uremic symptoms closely. 5. Collaborating with the nephrology team to ensure a coordinated approach to patient care. This systematic approach ensures that the intervention is evidence-based, patient-centered, and ethically sound, prioritizing the patient's overall well-being and functional status. Question 3. Cost-benefit analysis shows that implementing a comprehensive, individualized nutritional intervention plan for patients with newly diagnosed glomerular diseases, which includes detailed patient education, regular follow-up, and collaborative goal setting with the nephrology team, yields significant improvements in patient outcomes and quality of life compared to a standardized, less personalized approach. Considering the ethical and regulatory framework for renal nutrition specialists, which of the following represents the most appropriate initial step in developing such a plan for a patient presenting with IgA nephropathy? Option A. Prioritize aggressive sodium restriction to manage blood pressure, as this is a primary concern in most renal conditions, and defer detailed dietary counseling until other medical issues are stabilized. Option B. Immediately implement a strict low-protein diet with a focus on specific micronutrient supplementation, as this is a common intervention for many glomerular diseases. Option C. Provide the patient with a generic handout on kidney-friendly diets and schedule a follow-up appointment in 6 months to assess adherence. Option D. Conduct a thorough nutritional assessment, including dietary intake analysis, anthropometric measurements, biochemical markers, and a detailed understanding of the patient's lifestyle, cultural preferences, and socioeconomic factors, in conjunction with reviewing the specific diagnostic findings and nephrologist's recommendations for IgA nephropathy management. The correct answer is D. Conduct a thorough nutritional assessment, including dietary intake analysis, anthropometric measurements, biochemical markers, and a detailed understanding of the patient's lifestyle, cultural preferences, and socioeconomic factors, in conjunction with reviewing the specific diagnostic findings and nephrologist's recommendations for IgA nephropathy management. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the renal nutrition specialist to balance the immediate clinical needs of a patient with a newly diagnosed, complex glomerular disease against the long-term implications of treatment adherence and potential disease progression. The specialist must consider not only the efficacy of interventions, but also their feasibility and sustainability for the patient, which can be influenced by socioeconomic factors, patient understanding, and the availability of resources. The inherent variability in glomerular disease presentation and response to treatment further complicates decision-making, necessitating a personalized and evidence-based approach. Correct approach analysis. The correct approach prioritizes a comprehensive assessment of the patient's individual needs, disease characteristics, and treatment goals before implementing a nutritional plan. This aligns with the ethical principle of beneficence and non-maleficence, ensuring that interventions are tailored to maximize benefit and minimize harm. It also reflects the professional standard of care for renal nutrition specialists, which mandates individualized care plans based on thorough evaluation and current evidence-based guidelines for managing glomerular diseases. This approach respects patient autonomy by involving them in the decision-making process and considering their preferences and capabilities. Incorrect approach is analysis, an approach that solely focuses on aggressive dietary protein restriction without considering the specific type of glomerulonephritis, the patient's overall nutritional status, or their ability to adhere to such a restrictive regimen represents a regulatory and ethical failure. This could lead to malnutrition, muscle wasting, and a diminished quality of life, violating the principle of non-maleficence. It also fails to adhere to evidence-based practice, as protein restriction is not universally indicated or beneficial for all glomerular diseases and can be detrimental in certain contexts. An approach that neglects to involve the patient in the development of the nutritional plan, imposing a rigid set of recommendations without understanding their lifestyle, cultural preferences, or financial constraints, is ethically unsound. This violates the principle of patient autonomy and can lead to poor adherence and treatment failure. From a regulatory perspective, it fails to meet the standard of patient-centered care, which is increasingly emphasized in healthcare guidelines. An approach that relies on outdated or unverified nutritional interventions for glomerular diseases without consulting current research or professional guidelines is a failure of due diligence and professional competence. This could result in ineffective or even harmful recommendations, contravening the ethical obligation to provide care based on the best available evidence and potentially violating professional practice standards. Professional reasoning. Professionals should approach this situation by first conducting a thorough patient assessment, including a detailed dietary history, anthropometric measurements, biochemical data, and an understanding of the specific glomerular disease diagnosis and its stage. This should be followed by a review of current, evidence-based guidelines for managing the identified glomerular disease, considering both pharmacological and nutritional interventions. Collaboration with the nephrology team is crucial for a holistic treatment plan. Patient education and shared decision-making are paramount, ensuring the patient understands their condition, treatment options, and the rationale behind proposed nutritional strategies. The nutritional plan should be individualized, practical, and regularly monitored, and adjusted based on the patient's response, tolerance, and evolving clinical status. Question 4. The risk matrix shows a patient with stage 4 CKD and type 2 diabetes presenting with suboptimal glycemic control, HbA1c 5%, and elevated LDL cholesterol. The patient expresses concern about feeling fatigued and experiencing constipation. Considering the interplay of macronutrients on kidney function, glycemic control, and cardiovascular health, which of the following approaches best aligns with current U.S. renal nutrition guidelines and best professional practice? Option A. Focus on a high-protein, low-carbohydrate diet to manage diabetes and preserve muscle mass, with minimal attention to the type of fats consumed. Option B. Recommend a diet high in saturated fats and refined carbohydrates to increase energy intake and improve patient satisfaction, while monitoring electrolytes. Option C. Implement a high-fiber, complex carbohydrate-focused meal plan, emphasizing whole grains and legumes, while moderating saturated and trans fats and ensuring adequate protein intake tailored to CKD stage. Option D. Significantly restrict all carbohydrate intake to improve glycemic control, prioritizing simple sugars and refined grains for ease of digestion, and recommend a very low-fat diet. The correct answer is C. Implement a high-fiber, complex carbohydrate-focused meal plan, emphasizing whole grains and legumes, while moderating saturated and trans fats and ensuring adequate protein intake tailored to CKD stage. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the renal nutrition specialist to balance conflicting dietary recommendations for a patient with chronic kidney disease, CKD, who also has type 2 diabetes. The patient's glycemic control is a primary concern, necessitating careful carbohydrate management, while their CKD status demands attention to protein, potassium, phosphorus, and fluid. Furthermore, the patient's cardiovascular health, influenced by fat intake, adds another layer of complexity. The specialist must integrate these competing needs into a cohesive, evidence-based, and patient-centered nutrition care plan, adhering strictly to U.S. regulatory frameworks and guidelines relevant to renal nutrition. Correct approach analysis. The correct approach prioritizes a comprehensive assessment of the patient's current nutritional status, CKD stage, glycemic control, cardiovascular risk factors, and individual preferences. This involves a detailed review of laboratory values e.g. HbA1c, eGFR, lipid panel, medication regimen, and dietary intake. Based on this assessment, the specialist would develop a personalized macronutrient plan that strategically manages carbohydrate intake to optimize glycemic control without exacerbating CKD progression. This includes selecting complex carbohydrates with high fiber content to promote satiety and slow glucose absorption, while being mindful of potassium and phosphorus in high-fiber sources. Fat intake would be adjusted to support cardiovascular health, emphasizing monounsaturated and polyunsaturated fats and limiting saturated and trans fats, all within the context of CKD-specific recommendations. This approach aligns with the Academy of Nutrition and Dietetics evidence-based practice for renal nutrition and relevant U.S. federal regulations, e.g. those governing Medicare/Medicaid coverage for renal dialysis services and nutrition therapy. By ensuring patient safety, efficacy of care, and adherence to established professional standards. Incorrect approach is analysis, an approach that solely focuses on strict carbohydrate restriction to achieve glycemic control without considering the impact on protein intake, electrolyte balance, or the patient's overall energy needs would be a regulatory and ethical failure. This could lead to unintended consequences such as muscle wasting, electrolyte imbalances, and inadequate calorie intake, all of which are detrimental to a CKD patient and violate the principle of providing safe and effective nutrition care. An approach that prioritizes a low-fat diet for cardiovascular health without adequately assessing the patient's energy requirements and the potential impact on glycemic control would also be professionally unacceptable. If the reduction in fat leads to an increase in refined carbohydrates to meet energy needs, it could worsen glycemic control. Conversely, if the low-fat approach leads to insufficient calorie intake, it could result in malnutrition, a significant concern in CKD patients. An approach that recommends a high-fiber diet without considering the patient's specific CKD stage and potential for hyperkalemia or hyperphosphatemia would be a failure to adhere to individualized care principles. While fiber is generally beneficial, certain high-fiber foods are also high in potassium and phosphorus, which require careful monitoring and potential restriction in advanced CKD. This could lead to dangerous electrolyte imbalances. Professional reasoning. Professionals should employ a systematic, evidence-based decision-making process that begins with a thorough patient assessment. This involves gathering all relevant clinical data, understanding the patient's medical history and comorbidities, and identifying the primary nutrition-related goals. The next step is to apply current, evidence-based guidelines for renal nutrition and diabetes management, considering the interplay between macronutrients and their impact on kidney function, metabolic parameters, and cardiovascular health. Crucially, the plan must be individualized to the patient's specific needs, preferences, and tolerance. Regular monitoring and evaluation of the patient's response to the nutrition intervention are essential, with adjustments made as necessary. This iterative process ensures that the care provided is safe, effective, and compliant with professional standards and regulatory requirements. Question 5. Benchmark analysis indicates that a patient with chronic kidney disease, CKD, stage 4 presents with a reported decrease in appetite over the past month, a 5% unintentional weight loss in the last 3 months, and laboratory values showing a serum albumin of 3, 2G/DL, prealbumin of 15 mg/DL, and a hemoglobin of 10, 5G/DL. Which of the following approaches best reflects a comprehensive and best practice nutritional assessment for this patient? Option A. Recommend a fluid restriction and monitor electrolyte levels closely, as these are the primary concerns in CKD stage 4. Option B. Initiate a high-protein diet and supplement with oral nutritional support based on the low albumin and hemoglobin levels. Option C. Conduct a detailed dietary history, including a 24-hour recall and food frequency questionnaire, and utilize a validated malnutrition screening tool while considering the impact of inflammation on biochemical markers. Option D. Focus solely on the patient's reported decrease in appetite and initiate appetite stimulants without further objective nutritional assessment. The correct answer is B. Initiate a high-protein diet and supplement with oral nutritional support based on the low albumin and hemoglobin levels. Explanation. This scenario is professionally challenging because it requires the renal dietitian to integrate multiple data points from various assessment methods to accurately identify and address malnutrition in a complex patient population. The patient's declining appetite, weight loss, and altered biochemical markers necessitate a comprehensive and nuanced approach, moving beyond single data points. Careful judgment is required to prioritize interventions and avoid misdiagnosis or inappropriate treatment, which could exacerbate the patient's condition or lead to unnecessary resource utilization. The correct approach represents best professional practice by employing a multifaceted nutritional assessment strategy that aligns with established guidelines for the board's Certified Specialist in Renal Nutrition, CSR. This approach prioritizes a thorough evaluation of anthropometric data, biochemical parameters, and dietary intake, alongside a validated malnutrition screening tool. This comprehensive methodology ensures that the dietitian is not relying on a single indicator, but is building a holistic picture of the patient's nutritional status. This aligns with the ethical imperative to provide evidence-based, patient-centered care and the regulatory expectation to conduct thorough assessments as a foundation for individualized nutrition care plans. An incorrect approach that relies solely on a single biochemical marker, such as albumin, fails to account for the multifactorial nature of albumin levels in renal disease, which can be influenced by inflammation, hydration status, and protein losses, independent of nutritional intake. This approach risks misinterpreting the patient's nutritional status and delaying appropriate interventions. Another incorrect approach that focuses only on subjective patient reports without objective data fails to meet the standard of care for a comprehensive nutritional assessment, potentially leading to an incomplete or inaccurate diagnosis of malnutrition. Relying exclusively on a single dietary assessment method, like a 24-hour recall, without corroboration from other methods or objective data, can also be misleading due to recall bias or variations in daily intake. These approaches are ethically problematic as they do not uphold the duty of care to conduct a complete and accurate assessment, and they may violate professional standards that mandate the use of multiple assessment modalities. The professional decision-making process for similar situations should involve a systematic approach. First, recognize the patient's presenting symptoms and risk factors for malnutrition. Second, select and apply appropriate validated assessment tools and methods, ensuring a combination of subjective and objective data. Third, critically interpret the findings from each assessment component, considering the unique physiological context of renal disease. Fourth, synthesize all data to form a diagnosis and develop an individualized, evidence-based nutrition care plan. Finally, continuously monitor and reevaluate the patient's nutritional status and the effectiveness of interventions. Question 6. Quality control measures reveal a patient with newly diagnosed renal artery stenosis, presenting with significantly elevated blood pressure and evidence of hypertensive nephropathy on renal biopsy. The patient also reports intermittent flank pain and swelling in the lower extremities. Considering the pathophysiology of renal artery stenosis and its potential complications, which of the following nutritional management strategies would be most appropriate as an initial approach? Option A. Implement a comprehensive nutrition care plan focusing on optimizing protein intake to support renal function, managing sodium and fluid balance to control hypertension and edema, and monitoring potassium and phosphorus levels based on laboratory results and medical orders. Option B. Prioritize a low-potassium diet to prevent hyperkalemia, assuming this is a common complication of renal vascular disease, and recommend a moderate protein intake. Option C. Focus primarily on managing fluid overload through aggressive fluid restriction and a low-sodium diet, while deferring detailed protein and electrolyte management until further diagnostic information is available. Option D. Initiate a strict low-protein diet to minimize nitrogenous waste products and reduce the workload on the kidneys, without specific attention to fluid or electrolyte management beyond general recommendations. Correct answer is A. Implement a comprehensive nutrition care plan focusing on optimizing protein intake to support renal function, managing sodium and fluid balance to control hypertension and edema, and monitoring potassium and phosphorus levels based on laboratory results and medical orders. Explanation. This scenario is professionally challenging due to the critical nature of renal vascular diseases and their direct impact on kidney function, requiring a nuanced understanding of pathophysiology and its clinical manifestations within the established regulatory framework for renal nutrition specialists. The need to integrate evidence-based practice with patient-specific needs, while adhering to the CSR exam-specific guidelines, demands careful judgment. The correct approach represents best professional practice because it directly addresses the patient's complex renal vascular condition by tailoring the nutritional management to the specific pathophysiology of renal artery stenosis and its sequelae, such as hypertensive nephropathy. This aligns with the CSR's mandate to provide specialized, evidence-based nutrition care for individuals with kidney disease, emphasizing the integration of medical management and nutritional interventions. Adherence to established guidelines for managing hypertension and fluid/electrolyte balance in renal disease is paramount. An incorrect approach that focuses solely on general protein restriction without considering the specific etiology of the renal vascular disease fails to address the underlying issues contributing to the patient's condition. This could lead to suboptimal outcomes and potentially exacerbate the disease progression, violating the principle of providing individualized and targeted nutritional therapy. Another incorrect approach that neglects the potential for renal vein thrombosis and its implications for fluid management and protein handling would be a significant oversight. Ignoring this possibility could lead to inappropriate recommendations regarding fluid and sodium intake, potentially worsening edema and contributing to further renal damage. This demonstrates a failure to conduct a comprehensive assessment and consider all relevant pathophysiological aspects. A third incorrect approach that prioritizes a low-potassium diet without a clear indication from laboratory values or specific medical orders would be inappropriate. While potassium management is crucial in renal disease, it must be guided by objective data and physician recommendations, not assumed based on a general diagnosis. This highlights the importance of interdisciplinary collaboration and evidence-based decision-making. The professional decision-making process for similar situations should involve a thorough patient assessment, including a review of medical history, laboratory data, current medications, and clinical presentation. This should be followed by an analysis of the specific renal vascular pathology and its impact on nutritional status and requirements. The development of a personalized nutrition care plan, in collaboration with the healthcare team, is essential. This plan must be evidence-based, patient-centered, and regularly reassessed for efficacy and safety, always within the scope of practice defined by the CSR certification and relevant regulatory guidelines. Question 7. The audit findings indicate that a renal nutrition specialist's approach to a patient presenting with sudden onset of oliguria, elevated serum creatinine, and decreased urine output was reviewed. The specialist is tasked with developing an initial nutritional intervention strategy. Which of the following approaches best reflects a proactive risk assessment aligned with current renal nutrition practice guidelines for acute kidney injury (EKI? Option A. Focus solely on adjusting the patient's current maintenance enteral formula to a standard renal formula without further investigation into the AKI's cause or severity. Option B. Immediately initiate a high-protein, high-potassium diet to address potential catabolism and electrolyte losses associated with the acute illness. Option C. Prioritize the review of the patient's medication list for nephrotoxic agents and defer nutritional assessment until the AKI etiology is definitively diagnosed by the nephrology team. Option D. Conduct a comprehensive assessment of the patient's fluid and electrolyte balance. Identify potential etiologies of AKI, pre-renal, intrinsic, post-renal, using clinical signs and KDIGO criteria, and evaluate the patient's current nutritional status to anticipate metabolic changes and guide initial nutritional support. The correct answer is D. Conduct a comprehensive assessment of the patient's fluid and electrolyte balance. Identify potential etiologies of AKI, pre-renal, intrinsic, post-renal, using clinical signs and KDIGO criteria, and evaluate the patient's current nutritional status to anticipate metabolic changes and guide initial nutritional support. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the renal nutrition specialist to synthesize complex clinical data, apply specific diagnostic criteria, KDIGO, and make critical management decisions in a rapidly evolving, life-threatening condition. The challenge lies in accurately identifying the etiology of AKI, staging it appropriately, and then tailoring nutritional interventions to address the underlying cause and metabolic derangements, all while adhering to strict regulatory guidelines for patient care and documentation. The risk assessment approach is paramount to proactively identify and mitigate potential complications. Correct approach analysis. A risk assessment approach is the best professional practice because it aligns with the principles of evidence-based medicine and patient safety, as mandated by regulatory frameworks governing healthcare professionals. Specifically, for AKI management, it allows for the systematic identification of factors contributing to the AKI, pre-renal, intrinsic, post-renal, assessment of the severity using KDIGO staging, and prediction of potential complications such as electrolyte imbalances, fluid overload, and worsening nutritional status. This proactive approach enables the renal nutrition specialist to anticipate needs, prioritize interventions, and develop a personalized nutritional care plan that supports recovery and minimizes morbidity, thereby fulfilling ethical obligations to provide competent and safe care. And correct approaches analysis. Focusing solely on immediate fluid resuscitation without a comprehensive risk assessment for the underlying AKI etiology is a failure to adhere to best practices. This approach neglects the KDIGO guidelines' emphasis on identifying the cause of AKI, which is crucial for effective management. It could lead to inappropriate fluid administration, potentially exacerbating fluid overload in intrinsic or post-renal AKI, and failing to address the root cause, thus violating the ethical duty of care and potentially contravening regulatory requirements for evidence-based practice. Implementing a standardized, one-size-fits-all nutritional prescription without a thorough risk assessment of the patient's specific AKI stage, etiology, and metabolic status is also professionally unacceptable. This ignores the individualized nature of renal nutrition therapy and the dynamic changes that occur in AKI. Such an approach risks providing inadequate or excessive nutrients, leading to adverse outcomes and failing to meet the patient's unique needs, which is a breach of professional responsibility and potentially regulatory noncompliance regarding personalized patient care. Prioritizing medication adjustments over a comprehensive risk assessment of the AKI's impact on nutritional status is another flawed approach. While medication management is critical in AKI, the renal nutrition specialist's role is to assess and manage the nutritional consequences. Neglecting this assessment and focusing solely on pharmacotherapy without considering the patient's metabolic state, fluid balance, and nutrient requirements would be a failure to provide holistic care, potentially leading to malnutrition or other nutritional complications, and not fully meeting the scope of practice expected under regulatory oversight. Professional reasoning. The professional decision-making process for AKI management, particularly from a renal nutrition perspective, should begin with a thorough risk assessment. This involves 1. Identifying potential risk factors for AKI. 2. Evaluating the patient's current clinical status to determine the likely etiology, pre-renal, intrinsic, post-renal, and stage of AKI using KDIGO criteria. 3. Assessing the patient's fluid and electrolyte status, metabolic profile, and existing nutritional status. 4. Predicting potential complications and nutritional needs based on the AKI's severity and cause. 5. Developing and implementing an individualized nutritional care plan that addresses these findings in collaboration with the interdisciplinary team. This systematic, risk-based approach ensures that interventions are targeted, effective, and aligned with regulatory and ethical standards for patient care. Question 8. Quality control measures reveal that a patient with end-stage renal disease (ESID) on hemodialysis is experiencing generalized edema, shortness of breath, and a serum potassium level of 6.2 mg/L. Their most recent arterial blood gas analysis indicates a serum bicarbonate of 18 mg/L. The patient reports feeling fatigued and has a dry mouth. Considering the complex interplay of fluid and electrolyte imbalances in ESID, which of the following represents the most appropriate initial nutritional and collaborative approach? Option A. Recommend a high-protein diet to improve overall nutritional status and combat fatigue, with no immediate changes to fluid or potassium intake pending further assessment. Option B. Immediately initiate a very low potassium diet and aggressive fluid restriction, assuming hyperkalemia is the primary issue and fluid overload is secondary. Option C. Focus solely on increasing dietary intake of potassium-rich foods to counteract the reported fatigue, while addressing the edema with increased fluid intake. Option D. Implement a strict low-potassium diet and a moderate fluid restriction, while closely monitoring serum electrolytes and fluid status, and collaborating with the nephrology team to assess the need for dialysis adjustments or medication. The correct answer is D. Implement a strict low-potassium diet and a moderate fluid restriction, while closely monitoring serum electrolytes and fluid status, and collaborating with the nephrology team to assess the need for dialysis adjustments or medication. Explanation. Scenario analysis. This case presents a common yet complex challenge in renal nutrition management. A patient with end-stage renal disease (ESID) exhibiting symptoms suggestive of both fluid overload and electrolyte derangements. The interplay between these conditions, particularly hyperkalemia and metabolic acidosis, requires a nuanced understanding of renal physiology and the impact of dietary interventions. The professional challenge lies in differentiating the primary driver of the patient's symptoms and implementing an evidence-based, patient-centered plan that addresses multiple, potentially competing nutritional needs while adhering to regulatory guidelines for patient care. Correct approach analysis. The correct approach prioritizes a comprehensive assessment of the patient's current nutritional status, fluid balance, and electrolyte levels, integrating this with their medical history and current treatment regimen. This aligns with the principles of evidence-based practice and the scope of practice for a board-certified specialist in renal nutrition, CSR. Specifically, it emphasizes the need for collaboration with the interdisciplinary team, including nephrologists and nurses, to ensure a holistic and safe approach. This collaborative strategy is crucial for accurate diagnosis and effective management of complex fluid and electrolyte disorders in ESID, as mandated by professional standards and ethical practice guidelines that underscore patient safety and optimal outcomes. The focus on individualized care, considering the patient's specific dietary intake, medication adherence, and dialysis prescription, is paramount. Incorrect approach is analysis. An approach that solely focuses on restricting potassium without a thorough assessment of fluid status and acid-base balance is problematic. This could lead to unnecessary dietary limitations, potentially impacting nutritional adequacy, and may not address the root cause of the hyperkalemia if it's secondary to fluid overload or uncorrected acidosis. This failure to conduct a comprehensive assessment violates the principle of individualized care and could lead to suboptimal patient outcomes. An approach that immediately suggests aggressive fluid restriction without considering the patient's hydration status and the potential for dehydration, especially if they are experiencing symptoms like dry mucous membranes or decreased urine output, if applicable, is also flawed. This could exacerbate other issues and does not reflect a balanced approach to fluid management in renal disease. It overlooks the critical need to assess the *degree* of fluid overload and its impact on electrolyte distribution. An approach that solely targets metabolic acidosis with dietary interventions without considering the patient's potassium status and fluid balance is incomplete. While dietary modifications can influence acid-base balance, ignoring the concurrent hyperkalemia and potential fluid overload would be a significant oversight, potentially leading to dangerous consequences. This demonstrates a lack of integrated problem-solving. Professional reasoning. Professionals should approach this scenario by first gathering all available data: recent laboratory values, serum electrolytes, BUN, creatinine, bicarbonate, vital signs, physical assessment findings, edema, lung sounds, skin turgor, dialysis prescription, and current dietary intake. This information should be discussed with the nephrology team to confirm the diagnosis and treatment goals. The CSR should then formulate a nutrition care plan that addresses the identified fluid and electrolyte imbalances, prioritizing interventions that are evidence-based and tailored to the patient's individual needs and tolerance. This involves a systematic process of assessment, diagnosis, intervention, and monitoring, with continuous communication and collaboration with the healthcare team. Question 9. Risk assessment procedures indicate that a patient with chronic kidney disease, CKD stage 4, is experiencing increasing fatigue and generalized weakness. Recent laboratory results show a declining estimated glomerular filtration rate, eGFR, a slight elevation in serum potassium, and a mild decrease in serum bicarbonate. The patient's current dietary intake is reportedly inconsistent, considering the nephron's role in electrolyte and acid-base balance, and the kidney's endocrine functions. Which of the following nutritional management strategies would be most appropriate to address the patient's current clinical presentation and laboratory findings? Option A. Recommend a high-protein diet to combat fatigue and weakness, with a focus on increasing intake of potassium-rich fruits and vegetables to improve overall nutrient density. Option B. Implement a moderate protein diet, focusing on high biological value protein sources, while closely monitoring serum potassium and bicarbonate levels and adjusting fluid intake to support renal perfusion. Option C. Advise a low-protein, low-potassium diet without considering the patient's specific acid-base status or other electrolyte levels, assuming these are secondary to protein restriction. Option D. Increase the patient's intake of phosphorus-containing foods to improve energy levels, and recommend a high-sodium diet to enhance fluid retention and combat weakness. Correct answer is B. Implement a moderate protein diet, focusing on high biological value protein sources, while closely monitoring serum potassium and bicarbonate levels and adjusting fluid intake to support renal perfusion. Explanation. This scenario presents a professional challenge due to the complex interplay of a patient's declining renal function, potential electrolyte imbalances, and the need for precise nutritional management within the established regulatory framework for renal nutrition specialists. The challenge lies in accurately assessing the patient's current physiological state and predicting the impact of various dietary interventions on their delicate acid-base and electrolyte balance, all while adhering to the CSR's scope of practice and ethical guidelines. Careful judgment is required to differentiate between appropriate nutritional support and interventions that could exacerbate the patient's condition or lead to adverse outcomes. The correct approach represents best professional practice because it prioritizes a comprehensive, evidence-based assessment of the patient's current renal status and metabolic profile. This involves a thorough review of laboratory values, clinical presentation, and medication history to inform a personalized nutrition care plan. This approach aligns with the CSR's mandate to provide specialized nutrition support for individuals with kidney disease, emphasizing the application of scientific knowledge to optimize patient outcomes. It reflects a commitment to patient safety and adherence to the ethical principles of beneficence and non-maleficence by ensuring interventions are tailored and monitored. An incorrect approach that focuses solely on increasing protein intake without considering the patient's glomerular filtration rate, GFR, and potential for uremic toxin accumulation would be a regulatory and ethical failure. This could lead to increased nitrogenous waste products, exacerbating uremia and potentially accelerating kidney damage, violating the principle of non-maleficence. Another incorrect approach that neglects to monitor serum potassium levels while recommending a diet high in potassium-rich foods would be a critical failure. This could result in hyperkalemia, a life-threatening condition that requires immediate medical attention and directly contravenes the CSR's responsibility to manage electrolyte balance safely. Furthermore, an approach that fails to consider the patient's acid-base status and recommends interventions that could worsen metabolic acidosis without appropriate medical oversight would be a significant ethical and professional lapse, potentially harming the patient. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's clinical data, including laboratory results, to identify specific physiological derangements. This should be followed by a critical review of current evidence-based guidelines for renal nutrition therapy. The CSR must then formulate a nutrition care plan that addresses the identified issues while considering potential risks and benefits, always prioritizing patient safety and collaborating with the interdisciplinary healthcare team. Continuous monitoring and reassessment are crucial to adjust the plan as the patient's condition evolves. Question 10. Assessment of a 68-year-old male patient with stage 4 chronic kidney disease, CKD, due to diabetic nephropathy reveals he is adamant about continuing a high-protein, low-carbohydrate diet he believes is beneficial for his overall health, despite evidence suggesting this pattern may exacerbate his renal burden and contribute to malnutrition. The registered dietitian nutritionist, RDN, has assessed his current intake and identified potential micronutrient deficiencies and inadequate protein management for his CKD stage. The RDN needs to determine the most appropriate course of action to ensure optimal nutritional care while respecting the patient's autonomy. Option A. Accept the patient's dietary choices without further intervention, as patient autonomy is paramount, and the RDN's role is limited to providing information if requested. Option B. Advise the patient to discontinue the high-protein, low-carbohydrate diet and adhere strictly to a generic renal diet plan without exploring the underlying reasons for his preferences or seeking his active participation in modifying the plan. Option C. Immediately implement a strict renal diet protocol, overriding the patient's preferences to prevent further kidney damage and malnutrition, as this is the standard of care for stage 4 CKD. Option D. Engage in a detailed discussion with the patient to understand the rationale behind his dietary choices. Educate him on the specific risks and benefits of his preferred diet in the context of his CKD, and collaboratively develop a modified plan that attempts to balance his preferences with evidence-based renal nutrition guidelines, involving the nephrologist in the decision-making process. The correct answer is D. Engage in a detailed discussion with the patient to understand the rationale behind his dietary choices. Educate him on the specific risks and benefits of his preferred diet in the context of his CKD, and collaboratively develop a modified plan that attempts to balance his preferences with evidence-based renal nutrition guidelines, involving the nephrologist in the decision-making process. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's expressed wishes and the registered dietitian nutritionist's (RDN) clinical judgment regarding the best course of nutritional management for advanced chronic kidney disease (CKD). The patient's desire to maintain a specific dietary pattern, even if potentially detrimental to their CKD progression and overall health, clashes with the RDN's ethical and professional obligation to provide evidence-based, patient-centered care that prioritizes health outcomes and minimizes harm. Navigating this requires a delicate balance of respecting patient autonomy while upholding professional standards and advocating for the patient's well-being within the established regulatory framework for renal nutrition. The correct approach represents best professional practice because it prioritizes a comprehensive, collaborative, and patient-centered strategy. It acknowledges the patient's autonomy by engaging in open dialogue, seeking to understand the underlying reasons for their dietary preferences, and exploring potential compromises. This approach aligns with ethical principles of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm, by aiming to optimize nutritional status and slow CKD progression. It also adheres to professional guidelines for RDNs in renal nutrition, which emphasize individualized care plans, patient education, and shared decision-making. By involving the nephrologist, the RDN ensures that the overall medical management is coordinated and that any nutritional recommendations are integrated with the patient's broader treatment plan, respecting the scope of practice for each healthcare professional. An incorrect approach that involves unilaterally imposing a restrictive diet without thorough patient engagement or physician consultation fails to respect patient autonomy and may lead to non-adherence, potentially worsening the patient's condition. This could be considered a breach of ethical practice by not fully considering the patient's values and preferences. Another incorrect approach, that of simply deferring to the patient's wishes without offering evidence-based alternatives or exploring the rationale behind their choices, neglects the RDN's professional responsibility to provide expert guidance and advocate for optimal health outcomes, potentially leading to harm through inaction or inadequate management. A third incorrect approach, that of solely focusing on the patient's stated dietary preference without considering the broader clinical context of their CKD, its etiology, and potential complications, demonstrates a lack of comprehensive assessment and could lead to suboptimal or even harmful recommendations. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly assess the patient's current nutritional status, CKD stage, etiology, and any coexisting conditions or complications. Second, actively listen to and empathetically understand the patient's dietary preferences, beliefs, and concerns, exploring the why behind their choices. Third, educate the patient about the evidence-based nutritional recommendations for their specific condition, clearly explaining the rationale, potential benefits, and risks associated with different dietary approaches, including their preferred one. Fourth, collaboratively develop a personalized nutrition care plan that attempts to integrate the patient's preferences with clinical best practices, seeking compromises where possible. Fifth, consult with the patient's nephrologist and other members of the healthcare team to ensure coordinated care and to gain their input on the proposed plan. Finally, continuously monitor the patient's response to the nutrition intervention and adjust the plan as needed, always prioritizing patient safety and well-being. Question 11. Comparative studies suggest that patients with chronic kidney disease, CKD, often present with complex micronutrient profiles. A patient with CKD stage 4 reports experiencing increased fatigue, muscle cramps, and a metallic taste in their mouth. They are currently taking a standard multivitamin purchased over the counter. Which of the following approaches best addresses this patient's presentation while adhering to best practices in renal nutrition? Option A. Advise the patient to increase their intake of sodium and potassium-rich foods to combat fatigue and muscle cramps, as these are common symptoms of electrolyte depletion in CKD patients. Option B. Conduct a comprehensive dietary assessment. Review recent laboratory values, including electrolytes, iron studies, and vitamin levels if indicated, and consult current renal nutrition guidelines to determine the most appropriate targeted intervention, which may include adjusting or discontinuing the current supplement and recommending specific dietary changes or prescribed supplements. Option C. Recommend a high-dose, broad-spectrum micronutrient supplement specifically formulated for athletes, as fatigue and muscle cramps can be indicative of electrolyte imbalances common in active individuals. Option D. Immediately discontinue the over-the-counter multivitamin and advise the patient to increase their intake of fruits and vegetables to address potential vitamin deficiencies. The correct answer is B. Conduct a comprehensive dietary assessment. Review recent laboratory values, including electrolytes, iron studies, and vitamin levels if indicated, and consult current renal nutrition guidelines to determine the most appropriate, targeted intervention, which may include adjusting or discontinuing the current supplement and recommending specific dietary changes or prescribed supplements. Explanation. Scenario analysis. This scenario presents a common challenge in renal nutrition where a patient with chronic kidney disease, CKD, is experiencing symptoms that could be related to multiple micronutrient imbalances. The challenge lies in differentiating the cause of the symptoms and determining the most appropriate intervention, considering the complex interplay of micronutrients in CKD and the potential for iatrogenic harm from inappropriate supplementation. The patient's self-reported symptoms, coupled with their CKD status, necessitate a careful, evidence-based approach that prioritizes patient safety and adherence to established renal nutrition guidelines. Correct approach analysis. The correct approach involves a comprehensive assessment of the patient's current dietary intake, laboratory values, and medication profile, followed by a targeted intervention based on established renal nutrition guidelines. This aligns with the principles of evidence-based practice and the scope of practice for a board-certified specialist in renal nutrition, CSR. Specifically, the CSR is expected to 1. Evaluate current dietary intake for adequacy and potential excesses of micronutrients relevant to CKD, e.g., sodium, potassium, phosphorus. 2. Review recent laboratory data, e.g., serum electrolytes, albumin, iron studies, vitamin levels if indicated, to identify specific deficiencies or toxicities. 3. Consider the patient's CKD stage and any coexisting conditions that might influence micronutrient metabolism or requirements. 4. Consult current, evidence-based renal nutrition guidelines, e.g., those from the National Kidney Foundation KDOQI guidelines or similar authoritative bodies, to inform supplementation decisions. This systematic approach ensures that interventions are personalized, safe, and effective, minimizing the risk of adverse effects from unindicated supplementation. Incorrect approaches analysis. Initiating broad-spectrum micronutrient supplementation without a thorough assessment is a significant regulatory and ethical failure. This approach bypasses the essential diagnostic steps required to identify the root cause of the patient's symptoms. It risks oversupplementation, which can lead to toxicity, particularly with fat-soluble vitamins, A, E, K, and certain trace elements in CKD patients. For example, excessive vitamin A can be toxic in CKD, and unindicated iron supplementation can lead to iron overload. Furthermore, it fails to address potential dietary excesses or deficiencies that might be contributing to the symptoms, such as high sodium intake exacerbating fluid overload or inadequate intake of water-soluble vitamins leading to fatigue. This approach also disregards the principle of first, do no harm by introducing interventions without a clear indication and potential for benefit, while carrying a risk of harm. Another incorrect approach is to solely rely on the patient's self-reported symptoms to guide supplementation. While patient-reported symptoms are important, they are subjective and can be indicative of various underlying issues, not all of which are directly addressable by micronutrient supplementation. Without objective data from dietary assessment and laboratory values, any supplementation would be speculative and potentially harmful. This approach fails to uphold the professional responsibility to use objective data to inform clinical decisions. Finally, recommending over-the-counter supplements without considering their specific composition and potential interactions with the patient's CKD status and medications is also a failure. Many over-the-counter supplements are not formulated with the specific needs of CKD patients in mind and may contain ingredients that are contraindicated or harmful. For instance, some multivitamin formulations may contain excessive amounts of potassium or phosphorus, which are restricted in CKD. Professional reasoning. Professionals should adopt a systematic, evidence-based approach to micronutrient management in CKD. This involves 1. Thoroughly assessing the patient's clinical status, including symptoms, medical history, and current medications. 2. Conducting a detailed dietary assessment to evaluate intake of all relevant micronutrients. 3. Reviewing laboratory data to identify specific deficiencies or excesses. 4. Consulting current, evidence-based renal nutrition guidelines to inform diagnosis and treatment. 5. Developing a personalized nutrition intervention plan that may include dietary modifications and or targeted supplementation, with clear rationale and monitoring parameters. 6. Educating the patient about their condition, the rationale for interventions, and potential risks and benefits. This structured decision-making process ensures that interventions are safe, effective, and aligned with professional standards and regulatory requirements. Question 12. Compliance review shows a patient with a history of recurrent pyelonephritis and recent initiation of a new medication for an unrelated condition is now presenting with signs of declining renal function and proteinuria. The nephrology team suspects drug-induced interstitial nephritis as a potential cause, in addition to the possibility of exacerbation of chronic pyelonephritis. As a board-certified specialist in renal nutrition, CSR, what is the most appropriate initial approach to nutritional management? Option A. Collaborate with the nephrology team to obtain a definitive diagnosis regarding the cause of renal dysfunction before initiating specific dietary modifications beyond general renal support. Option B. Focus solely on managing electrolyte imbalances, particularly sodium and potassium, as these are common issues in patients with declining renal function. Option C. Recommend a high-potassium diet to counteract potential fluid shifts and support kidney function, given the patient's history and new medication. Option D. Immediately implement a low-protein diet to reduce the workload on the kidneys, assuming the decline is due to the underlying renal disease. The correct answer is A. Collaborate with the nephrology team to obtain a definitive diagnosis regarding the cause of renal dysfunction before initiating specific dietary modifications beyond general renal support. Explanation. Scenario analysis. This scenario presents a common yet complex challenge in renal nutrition management. A patient with a history of recurrent pyelonephritis and suspected drug-induced nephrotoxicity requires nutritional intervention. The challenge lies in differentiating the underlying causes of renal dysfunction, which directly impacts the appropriateness and safety of nutritional recommendations. Misinterpreting the etiology could lead to ineffective or even harmful dietary modifications, exacerbating the patient's condition and potentially violating the standard of care expected of a board-certified specialist in renal nutrition. CSR. The CSR credential signifies a commitment to evidence-based practice and patient safety within the specific regulatory framework governing renal nutrition in the United States. Correct approach analysis. The correct approach prioritizes a comprehensive assessment to identify the specific tubulointerstitial disease and its contributing factors. This aligns with the CSR's ethical obligation to provide individualized, evidence-based care. By collaborating with the nephrology team to obtain a definitive diagnosis, e.g., confirming drug-induced interstitial nephritis versus chronic pyelonephritis, the specialist ensures that nutritional interventions are targeted and safe. This approach adheres to the principles of patient-centered care and the ethical guidelines for dietitians in the U.S., which mandate accurate diagnosis and appropriate treatment planning. The CSR specialist's role is to support medical management, not to independently diagnose, thus emphasizing the importance of interdisciplinary collaboration. Incorrect approaches analysis. One incorrect approach involves immediately implementing a low-protein diet without a confirmed diagnosis. This fails to acknowledge the potential for drug-induced nephrotoxicity, which might require different management strategies than chronic pyelonephritis. Implementing a restrictive diet without a clear indication could lead to malnutrition and is not supported by evidence for all forms of tubulointerstitial disease. This violates the principle of providing evidence-based nutrition care and could be considered a deviation from the standard of practice, potentially leading to adverse patient outcomes. Another incorrect approach is to focus solely on electrolyte management without considering the underlying cause of renal dysfunction. While electrolyte imbalances are common in renal disease, neglecting the specific tubulointerstitial pathology means that the nutritional plan may not address the root cause or prevent further damage. This approach is reactive rather than proactive and does not reflect the comprehensive, holistic care expected of a CSR specialist. It overlooks the opportunity to mitigate the progression of the disease through targeted nutritional strategies. A third incorrect approach is to recommend a high-potassium diet to compensate for potential diuretic use, without confirming the patient's actual potassium levels and the specific reason for diuretic therapy. This could lead to hyperkalemia, a dangerous complication in renal patients, especially those with compromised kidney function. This demonstrates a failure to conduct a thorough assessment and to base recommendations on objective data, which is a fundamental ethical and professional requirement. Professional reasoning. Professionals should adopt a systematic approach that begins with a thorough patient assessment, including a detailed medical history, review of medications, and laboratory data. In cases of suspected tubulointerstitial disease, collaboration with the nephrology team is paramount to establish a definitive diagnosis. Nutritional interventions should then be tailored to the specific diagnosis, considering the pathophysiology, clinical manifestations, and potential impact of the disease on nutrient metabolism and excretion. This involves ongoing monitoring and adjustment of the nutrition care plan based on the patient's response and changes in their clinical status. Adherence to established guidelines for renal nutrition in the U.S., such as those provided by the Academy of Nutrition and Dietetics, is essential. Question 13. To address the challenge of initiating appropriate nutritional support for a critically ill patient with acute kidney injury, Aki, who is hemodynamically stable but experiencing significant fluid overload and hyperkalemia, which of the following strategies best aligns with current U.S. regulatory guidelines and best practices for renal nutrition specialists? Option A. Begin parenteral nutrition with a standard critically ill patient formula, focusing primarily on energy delivery and deferring detailed electrolyte management until the AKI stabilizes. Option B. Administer enteral nutrition tailored to the patient's estimated energy needs and protein requirements based on their catabolic state and dialysis status, with careful attention to electrolyte and fluid content and frequent monitoring. Option C. Initiate parenteral nutrition with a high protein content and moderate fluid volume, closely monitoring serum potassium levels for rapid correction. Option D. Prioritize enteral nutrition, starting with a low-protein, low-electrolyte formula and gradually increasing as tolerated, while implementing strict fluid restriction. The correct answer is C. Initiate parenteral nutrition with a high protein content and moderate fluid volume, closely monitoring serum potassium levels for rapid correction. Explanation. The scenario presents a critically ill patient with acute kidney injury, Aki, requiring nutritional support, a situation demanding immediate and precise intervention within the established regulatory framework for renal nutrition. The professional challenge lies in balancing the complex and often conflicting nutritional needs of AKI patients, particularly regarding protein and energy, while adhering to strict fluid and electrolyte management guidelines to prevent further renal compromise. The need for timely and appropriate initiation of enteral or parenteral nutrition, coupled with continuous monitoring, underscores the critical nature of this decision-making process. The correct approach emphasizes a personalized, evidence-based strategy that aligns with the board's certified specialist in renal nutrition, CSR, scope of practice, and relevant U.S. regulatory guidelines for nutrition support in critically ill patients. This involves a thorough assessment of the patient's metabolic status, fluid balance, and electrolyte levels to determine the most appropriate route and composition of nutrition. Prioritizing enteral nutrition when feasible, as it is generally preferred for gut integrity and reduced infection risk, is a cornerstone of best practice. Protein and energy requirements must be carefully titrated based on the patient's AKI stage, degree of catabolism, and dialysis status, adhering to current renal nutrition guidelines that advocate for adequate, not necessarily restricted, protein in many AKI scenarios to prevent malnutrition. Electrolyte and fluid management must be meticulously integrated into the nutrition plan, with frequent monitoring and adjustments to prevent hyperkalemia, hyperphosphatemia, and fluid overload, all of which are critical considerations under U.S. healthcare regulations governing patient care and safety. An incorrect approach would involve a one-size-fits-all protocol that fails to account for individual patient variability, such as rigidly restricting protein, without considering the patient's catabolic state or dialysis needs. This could lead to malnutrition and impaired recovery, violating ethical obligations to provide optimal care. Another incorrect approach might be to delay or inadequately initiate nutrition support due to uncertainty or a lack of comprehensive assessment, which could exacerbate catabolism and negatively impact patient outcomes, potentially falling short of accepted standards of care. Furthermore, failing to closely monitor and adjust electrolyte and fluid content in the nutrition formula based on the patient's dynamic AKI status would represent a significant regulatory and ethical failure, as it directly impacts patient safety and could lead to life-threatening complications. The professional decision-making process should involve a systematic evaluation of the patient's clinical status, laboratory data, and nutritional requirements. This includes consulting current evidence-based guidelines for AKI nutrition, utilizing validated assessment tools, and collaborating with the interdisciplinary healthcare team. The CSR specialist must then formulate a nutrition care plan that is individualized, safe, and effective, with a clear plan for ongoing monitoring and evaluation to ensure optimal patient outcomes within the U.S. regulatory framework. Question 14. Governance review demonstrates a hemodialysis patient experiencing persistent anemia despite current ESA and iron therapy. The patient's dietitian is considering dietary modifications. Which of the following approaches best reflects a comprehensive and safe nutritional intervention strategy for this patient? Option A. Focus solely on increasing iron-rich foods without considering other macronutrient and electrolyte implications. Option B. Increase protein intake significantly to support erythropoiesis while closely monitoring phosphorus and potassium levels. Option C. Advise increased fluid intake to help the body eliminate waste products, potentially aiding anemia management. Option D. Recommend a low-protein diet to reduce phosphorus load, assuming this will indirectly improve anemia. The correct answer is B. Increase protein intake significantly to support erythropoiesis while closely monitoring phosphorus and potassium levels. Explanation. Scenario analysis. This scenario presents a common challenge in renal nutrition where a patient's clinical status, anemia, intersects with complex dietary management for hemodialysis. The challenge lies in balancing the need for adequate protein to support erythropoiesis and overall well-being, with the potential for increased phosphorus and potassium burden, all within the strict fluid and sodium restrictions of hemodialysis. The dietitian must integrate multiple nutritional parameters and patient-specific factors to develop a safe and effective plan, adhering to established guidelines and the patient's individual needs. Correct approach analysis. The correct approach prioritizes a comprehensive assessment of the patient's current nutritional status, laboratory values, and clinical presentation. This includes evaluating the effectiveness of current interventions for anemia, such as erythropoiesis-stimulating agents, ESA, and iron supplementation, and how these might influence protein needs. It also necessitates a thorough review of the patient's phosphorus, potassium, sodium, and fluid intake, and adherence to current recommendations for hemodialysis patients. The goal is to identify specific dietary adjustments that can support erythropoiesis without exacerbating electrolyte imbalances or fluid overload. This aligns with the CSR exam's focus on evidence-based practice and individualized patient care within the regulatory framework of renal nutrition. Incorrect approach is analysis, an approach that solely focuses on increasing protein intake without a concurrent assessment of phosphorus and potassium levels is problematic. This fails to acknowledge the interconnectedness of these nutrients in renal patients and could lead to hyperphosphatemia and hyperkalemia, which are serious complications requiring immediate medical intervention and potentially impacting the effectiveness of anemia treatment. This approach neglects the fundamental principles of renal nutrition management. Another incorrect approach would be to recommend a blanket reduction in all protein intake to manage phosphorus without considering the patient's anemia and potential need for increased protein to support red blood cell production and overall nutritional status. This could lead to protein energy wasting, further complicating the patient's health and potentially hindering the response to anemia therapies. A third incorrect approach might involve increasing fluid intake to flush out toxins, without considering the patient's fluid restrictions for hemodialysis. This could lead to fluid overload, hypertension, and increased burden on the cardiovascular system, directly contradicting the management goals for hemodialysis patients. Professional reasoning. Professionals should employ a systematic, patient-centered decision-making framework. This involves 1. Thoroughly assessing the patient's current clinical and laboratory data, including anemia markers, electrolytes, and fluid status. 2. Reviewing existing dietary interventions and their adherence. 3. Identifying the primary nutritional concerns and their interrelationships, e.g., protein, phosphorus, potassium, fluid. 4. Developing a multifaceted intervention plan that addresses all identified issues concurrently and safely. 5. Collaborating with the nephrologist and other healthcare team members to ensure a coordinated approach. 6. Continuously monitoring the patient's response and adjusting the plan as needed. This iterative process ensures that interventions are evidence-based, individualized, and aligned with best practices in renal nutrition. Question 15. The monitoring system demonstrates that a patient with advanced chronic kidney disease, CKD, and superimposed acute kidney injury, AKI, has been initiated on enteral nutrition. The patient's serum potassium is 5.8 mg/L, serum phosphorus is 6.5 mg/dL, and fluid balance is currently positive by 1.5 liters over the last 24 hours. The patient is hemodynamically stable but experiencing mild nausea. Considering best practice for enteral nutrition in this complex renal population, which of the following approaches is most appropriate for advancing the patient's enteral nutrition regimen? Option A. Discontinue enteral nutrition temporarily and initiate parenteral nutrition to provide immediate nutritional support while awaiting stabilization of renal function. Option B. Increase the administration rate of the current renal-specific formula by 25% to meet estimated caloric needs and administer a phosphate binder with each feeding. Option C. Transition to a standard high-protein, high-electrolyte enteral formula to ensure adequate protein intake and increase the administration rate to meet estimated caloric needs. Option D. Continue the current renal-specific enteral formula at the current rate, monitor for resolution of nausea, and reassess laboratory values in 48 hours. Correct answer is D. Continue the current renal-specific enteral formula at the current rate, monitor for resolution of nausea, and reassess laboratory values in 48 hours. Explanation. This scenario is professionally challenging because it requires the renal nutrition specialist to balance the immediate need for nutritional support with the complex physiological changes occurring in a patient with advanced chronic kidney disease, CKD, and acute kidney injury, AKI. The patient's fluctuating fluid status, electrolyte imbalances, and potential for gastrointestinal intolerance necessitate a highly individualized and dynamic approach to enteral nutrition. The specialist must consider not only the caloric and protein needs, but also the specific nutrient profiles of the formulas to avoid exacerbating the patient's condition. The correct approach represents best professional practice because it prioritizes a comprehensive assessment of the patient's current clinical status, including laboratory values, fluid balance, and tolerance to previous nutrition interventions. This aligns with the principles of evidence-based practice and patient-centered care, as mandated by professional standards for board-certified specialists in renal nutrition. Specifically, selecting a renal-specific enteral formula that is lower in electrolytes and provides a more controlled protein and fluid load is crucial for managing AKI superimposed on CKD. The gradual increase in administration rate, coupled with vigilant monitoring for signs of intolerance or complications, demonstrates a proactive and safe approach to initiating and advancing enteral nutrition. This methodical process ensures that the patient receives adequate nutrition while minimizing the risk of adverse events, thereby supporting recovery and preventing further renal compromise. An incorrect approach that involves immediately initiating a standard high-protein, high-electrolyte enteral formula without considering the patient's renal status would be a significant regulatory and ethical failure. This would violate the principle of providing appropriate and safe patient care, potentially leading to hyperkalemia, hyperphosphatemia, fluid overload, and worsening uremia, which are directly contrary to the goals of renal nutrition therapy. Such an action would also fail to adhere to the professional responsibility of utilizing specialized knowledge to tailor nutrition interventions to specific disease states, as expected of a CSR. Another incorrect approach, such as discontinuing enteral nutrition altogether due to initial signs of intolerance without attempting to modify the formula or administration method, would also be professionally unacceptable. This could lead to malnutrition and hinder recovery, especially in a critically ill patient. The ethical obligation is to explore all reasonable therapeutic options to meet the patient's nutritional needs. Finally, an approach that focuses solely on caloric delivery without considering the specific nutrient composition of the formula in relation to the patient's renal function and electrolyte status would be a failure to apply specialized knowledge. This could inadvertently lead to the administration of excessive amounts of phosphorus, potassium, or fluid, exacerbating the patient's renal dysfunction. The professional decision-making process for similar situations should involve a systematic evaluation. First, assess the patient's current renal function, electrolyte status, and fluid balance. Second, determine the estimated nutritional needs, calories, protein, fluid. Third, select an appropriate enteral formula, prioritizing renal-specific formulas when indicated, considering electrolyte content, protein quality and quantity, and fluid volume. Fourth, initiate enteral nutrition at conservative rate and gradually advance as tolerated, with close monitoring. Fifth, continuously reassess the patient's tolerance, laboratory values, and clinical status, making adjustments to the nutrition regimen as needed. This iterative process ensures optimal patient outcomes and adherence to professional and ethical standards. Question 16. Market research demonstrates that effective management of acid-base balance is critical for patients with chronic kidney disease. A patient with stage 4 CKD presents with a serum bicarbonate of 18 mx/L, a PCO2 of 35 mmHg, and a pH of 7.32. The patient is currently on a standard renal diet. Which of the following nutritional adjustments would be the most appropriate initial approach to address this patient's acid-base status? Option A. Increase the intake of fruits and vegetables known to be alkalinizing while monitoring for hyperkalemia. Option B. Recommend a low-protein diet to reduce the metabolic acid load. Option C. Adjust fluid and electrolyte intake to support renal excretion of acids. Option D. Introduce a sodium bicarbonate supplement to directly increase serum bicarbonate levels. The correct answer is A. Increase the intake of fruits and vegetables known to be alkalinizing while monitoring for hyperkalemia. Explanation. This scenario is professionally challenging because it requires the renal nutrition specialist to integrate complex physiological data, arterial blood gases, with a patient's specific renal condition and dietary interventions, all within the strict regulatory framework governing patient care. The specialist must not only understand the pathophysiology of acid-base balance, but also apply this knowledge ethically and effectively to optimize patient outcomes while adhering to established professional standards and guidelines. The correct approach represents best professional practice because it prioritizes a comprehensive, evidence-based assessment of the patient's acid-base status and its relationship to their renal disease and nutritional plan. This involves a systematic interpretation of ABG values in the context of the patient's clinical presentation and renal function, leading to targeted nutritional interventions. This aligns with the ethical obligation to provide competent and individualized care, ensuring that nutritional strategies are safe, effective, and responsive to the patient's dynamic physiological state. Adherence to established guidelines for managing acid-base disorders in renal patients is paramount. An incorrect approach that focuses solely on one aspect of the ABG without considering the broader clinical picture or the patient's renal status would be professionally unacceptable. For instance, addressing only a low bicarbonate level without evaluating the pH and PCO2 could lead to inappropriate interventions, potentially exacerbating the underlying disorder or creating new complications. This failure to conduct a thorough, integrated assessment violates the principle of beneficence and non-maleficence, as it risks harm to the patient. Furthermore, neglecting to consider the renal contribution to acid-base balance in a renal patient is a fundamental oversight that contravenes the core competencies expected of a specialist in renal nutrition. Another incorrect approach might involve implementing a drastic dietary change based on a single ABG value, without considering the patient's overall nutritional status, dietary preferences, or potential impact on other renal parameters. This could lead to nutritional deficiencies or imbalances, violating the principle of providing safe and adequate nutrition. Such an approach demonstrates a lack of critical thinking and a failure to apply a holistic, patient-centered perspective, which is a cornerstone of ethical and effective renal nutrition practice. The professional decision-making process for similar situations should involve a systematic approach. 1. Thoroughly review the patient's medical history, current clinical status, and laboratory data, with particular attention to renal function markers and ABG results. 2. Interpret the ABG values comprehensively, considering pH, PCO2, and bicarbonate to determine the primary acid-base disorder, respiratory or metabolic, acidosis or alkalosis, and assess for compensation. 3. Correlate the ABG findings with the patient's renal disease stage and known pathophysiological mechanisms of acid-base imbalance in this population. 4. Evaluate the current nutritional regimen for its potential contribution to or mitigation of the acid-base disorder. 5. Develop a targeted nutritional intervention plan that addresses the identified acid-base imbalance while ensuring overall nutritional adequacy and safety, in collaboration with the healthcare team. 6. Continuously monitor the patient's response to interventions through repeat ABGs and other relevant clinical parameters. Question 17. Consider a scenario where a board-certified specialist in renal nutrition, CSR, is managing a patient with acute kidney injury, AKI, who is experiencing significant metabolic stress and is recommended to receive a specific energy-dense enteral formula to prevent malnutrition and support recovery. The patient, who is alert and oriented, expresses strong apprehension and refuses the recommended formula, stating they don't want anything going down a tube. The CSR has assessed the patient's energy status and determined that oral intake is insufficient to meet their estimated needs. What is the most ethically and professionally sound approach for the CSR to take in this situation? Option A. Immediately contact the patient's family to explain the situation and request their assistance in convincing the patient to accept the enteral formula. Option B. Document the patient's refusal of the enteral formula and cease further nutritional intervention, as the patient has the right to refuse treatment. Option C. Override the patient's refusal and initiate the enteral feeding as prescribed, explaining that it is medically necessary for their survival. Option D. Engage in a detailed conversation with the patient to understand the specific reasons for their apprehension. Provide clear and empathetic education about the importance of adequate energy intake for AKI recovery. Discuss the risks of malnutrition and explore potential alternatives or modifications to the feeding plan that might address their concerns while still meeting nutritional goals. The correct answer is D. Engage in a detailed conversation with the patient to understand the specific reasons for their apprehension. Provide clear and empathetic education about the importance of adequate energy intake for AKI recovery. Discuss the risks of malnutrition and explore potential alternatives or modifications to the feeding plan that might address their concerns while still meeting nutritional goals. Explanation. Scenario analysis. This scenario presents an ethical dilemma for a board-certified specialist in renal nutrition, CSR, regarding a patient with acute kidney injury, AKI, who is refusing a recommended energy-providing enteral formula. The challenge lies in balancing the patient's autonomy with the clinician's professional responsibility to provide optimal nutritional care, especially in a critical illness like AKI, where malnutrition can significantly worsen outcomes. The patient's refusal, potentially stemming from fear, misinformation, or a desire for control, creates a conflict that requires careful navigation to ensure the patient's well-being while respecting their rights. The CSR must consider the immediate physiological needs of AKI, the potential for rapid deterioration without adequate energy, and the long-term implications of nutritional deficits. Correct approach analysis. The correct approach involves a multifaceted strategy that prioritizes patient education, shared decision-making, and addressing the underlying reasons for refusal, all within the ethical and regulatory framework governing patient care. This aligns with the principles of beneficence, acting in the patient's best interest, and autonomy, respecting the patient's right to make informed decisions. The CSR should engage in a thorough discussion with the patient, explaining the rationale behind the enteral formula in clear, understandable terms, addressing their specific concerns and fears, and exploring alternative methods of nutritional support if feasible and appropriate for AKI management. This approach respects the patient's right to refuse treatment while actively working towards a solution that supports their recovery. It also implicitly adheres to guidelines that emphasize patient-centered care and informed consent, which are foundational in healthcare practice. Incorrect approaches analysis. One incorrect approach would be to override the patient's refusal and initiate the enteral feeding without further discussion or consent. This violates the principle of patient autonomy and could lead to a breakdown in the therapeutic relationship. Ethically, it constitutes a form of coercion and disrespects the patient's right to self-determination. Legally and regulatorily, it could be considered battery or a violation of informed consent principles, depending on the specific jurisdiction's healthcare laws. Another incorrect approach would be to simply document the refusal and discontinue further nutritional intervention without exploring alternatives or understanding the patient's reasoning. This fails to uphold the principle of beneficence, as the CSR is not acting to prevent potential harm, malnutrition, that could arise from the refusal. It represents a passive approach that neglects the professional responsibility to advocate for the patient's nutritional needs and to find solutions. This could be seen as a failure to meet professional standards of care, which require active problem-solving and patient engagement. A third incorrect approach would be to dismiss the patient's concerns as unfounded and insist on the original plan, without empathy or exploration. This demonstrates a lack of respect for the patient's perspective and can alienate them, making them less likely to cooperate with any future recommendations. It fails to acknowledge the psychological and emotional aspects of illness and treatment, which are crucial for effective patient care. This approach neglects the importance of building trust and rapport, essential components of a successful therapeutic relationship. Professional reasoning. When faced with a patient's refusal of a recommended nutritional intervention, the CSR should employ a systematic approach. First, actively listen to and acknowledge the patient's concerns and fears. Second, provide clear, patient-centered education about the rationale for the intervention, its benefits, and potential risks of not receiving it, tailored to the specific needs of AKI. Third, explore the underlying reasons for the refusal and address any misconceptions. Fourth, collaboratively discuss alternative options, if available and clinically appropriate, to find a mutually agreeable plan. Fifth, document the discussion, the patient's decision, and the rationale for the chosen course of action. This process ensures that patient autonomy is respected while striving to achieve the best possible clinical outcomes. Question 18. The investigation demonstrates a 65-year-old male patient with end-stage renal disease, ESID, on thrice-weekly in-center hemodialysis, experiencing recurrent episodes of hypotension during treatment, persistent fatigue, and laboratory values indicating suboptimal dialysis adequacy, e.g., KT/V consistently below target. The patient expresses dissatisfaction with his current treatment, citing the inconvenience and the physical toll it takes. He has a history of multiple central venous catheter placements due to arteriovenous fistula maturation issues. He also reports occasional missed meals due to his demanding work schedule. Considering the patient's complex clinical picture and expressed concerns, what is the most appropriate next step in managing his renal replacement therapy? Option A. Conduct a comprehensive evaluation of the patient's current hemodialysis prescription, access functionality, and nutritional intake, followed by a shared decision-making discussion with the patient regarding alternative dialysis modalities that may better suit his clinical needs and lifestyle. Option B. Refer the patient for a psychiatric evaluation to address potential non-adherence and psychological factors contributing to his reported dissatisfaction and suboptimal outcomes. Option C. Immediately increase the frequency of in-center hemodialysis treatments to 5 times per week to improve dialysis adequacy and address the patient's fatigue. Option D. Recommend a significant reduction in fluid intake and sodium restriction to mitigate hypotensive episodes during dialysis, without altering the dialysis schedule or modality. The correct answer is A. Conduct a comprehensive evaluation of the patient's current hemodialysis prescription, access functionality, and nutritional intake, followed by a shared decision-making discussion with the patient regarding alternative dialysis modalities that may better suit his clinical needs and lifestyle. Explanation. This scenario presents a professionally challenging situation due to the inherent complexity of managing a patient with end-stage renal disease (ESID), who is experiencing recurrent access issues and suboptimal dialysis adequacy, while also navigating the patient's personal preferences and potential for non-adherence. The challenge lies in balancing evidence-based best practices for renal replacement therapy with patient autonomy and the practical realities of their treatment. Careful judgment is required to assess the patient's current treatment effectiveness, identify the root causes of their complications, and propose a modality that optimizes outcomes while respecting their values. The correct approach represents best professional practice because it prioritizes a comprehensive, individualized assessment of the patient's clinical status, psychosocial factors, and treatment history. This aligns with the principles of patient-centered care, which are foundational in renal nutrition and dialysis management. By thoroughly evaluating the patient's current dialysis prescription, access functionality, and nutritional status, the clinician can identify specific deficiencies contributing to their suboptimal outcomes. Furthermore, engaging the patient in a discussion about alternative dialysis modalities, considering their lifestyle preferences and understanding of each option, upholds their right to informed consent and shared decision-making. This collaborative approach ensures that the chosen modality is not only clinically appropriate, but also sustainable and acceptable to the patient, thereby improving adherence and long-term success. This is consistent with the ethical imperative to provide the highest quality of care tailored to the individual needs of patients with ESID. An incorrect approach that focuses solely on increasing dialysis frequency without investigating the underlying access issues or patient adherence fails to address the root cause of the problem. This could lead to further complications, patient frustration, and continued suboptimal outcomes, potentially violating the ethical principle of beneficence by not acting in the patient's best interest. It also neglects the importance of a holistic assessment, which is crucial for effective renal nutrition management. Another incorrect approach that involves unilaterally changing the dialysis modality based on perceived patient non-adherence, without a thorough assessment or patient involvement, disregards patient autonomy and the right to informed consent. This paternalistic approach can erode trust, lead to resistance, and ultimately undermine the therapeutic relationship, potentially violating ethical guidelines regarding patient rights and shared decision-making. A further incorrect approach that solely focuses on dietary modifications without addressing the dialysis modality and access issues is incomplete. While nutrition is critical, it cannot compensate for inadequate dialysis clearance or recurrent access problems. This approach fails to recognize the interconnectedness of dialysis adequacy, access, and nutritional status in managing ESID, thereby not providing comprehensive care. The professional decision-making process for similar situations should involve a systematic, multifaceted approach. First, conduct a thorough clinical assessment, including review of dialysis records, laboratory values, and physical examination, to identify specific issues. Second, evaluate the patient's dialysis access for patency and function. Third, assess the patient's nutritional status and adherence to dietary recommendations. Fourth, engage the patient in an open and honest discussion about their current treatment, its limitations, and their personal goals and preferences. Fifth, explore all available dialysis modalities, e.g., hemodialysis, peritoneal dialysis, home hemodialysis, and their suitability for the individual patient, considering their clinical profile, psychosocial support, and lifestyle. Finally, collaboratively develop a treatment plan that is evidence-based, patient-centered, and addresses all identified issues. Question 19. Upon reviewing the medical records of a 68-year-old male patient with a glomerular filtration rate, eGFR, of 25 ml/min/1, 73M2, and a history of type 2 diabetes who is not yet on dialysis, what is the most appropriate initial approach to protein management, considering the potential for protein energy wasting? Option A. Recommend a protein intake of 0.8 grams per kilogram of ideal body weight per day, with an emphasis on high biological value protein sources. Option B. Implement a protein intake of 1.5 grams per kilogram of ideal body weight per day to proactively address potential protein energy wasting. Option C. Suggest a protein intake of 1.0 grams per kilogram of ideal body weight per day, without specific emphasis on protein quality to simplify dietary adherence. Option D. Advise a protein intake of 1.2 grams per kilogram of ideal body weight per day, focusing on a variety of protein sources to ensure adequate calorie intake. The correct answer is A. Recommend a protein intake of 0.8 grams per kilogram of ideal body weight per day, with an emphasis on high biological value protein sources. Explanation: this scenario is professionally challenging because it requires the renal dietitian to synthesize current evidence-based guidelines for protein intake across a spectrum of kidney disease stages and treatment modalities, while also considering the nuanced concept of protein quality and the potential for protein energy wasting, PEW. The dietitian must move beyond simple numerical targets to understand the underlying physiological principles and the impact of different protein sources. The correct approach represents best professional practice because it aligns with the most current recommendations from authoritative bodies such as the National Kidney Foundation Kidney Disease Outcomes Quality Initiative, NKF-KDOQI, and the International Society of Renal Nutrition and Metabolism, ISNM. These guidelines emphasize individualized protein prescriptions based on the patient's specific kidney function, eGFR, treatment modality, dialysis type, transplant status, and clinical indicators of nutritional status, including PEW. The focus on protein quality, specifically the biological value and amino acid composition, is crucial for optimizing nitrogen utilization and minimizing uremic toxin production, which is a cornerstone of effective renal nutrition therapy. This approach demonstrates a deep understanding of the complexities of protein metabolism in kidney disease and adheres to the ethical imperative of providing patient-centered, evidence-based care. An incorrect approach that focuses solely on a fixed percentage of calories from protein without considering the patient's specific stage of CKD, dialysis status, or presence of PEW, fails to acknowledge the dynamic nature of protein needs in renal disease. This is a regulatory failure, as it deviates from established guidelines that advocate for individualized protein prescriptions. Ethically, it risks either inadequate protein provision, exacerbating PEW, or excessive protein intake, potentially accelerating disease progression and increasing the burden of uremic toxins. Another incorrect approach that disregards protein quality and focuses only on total protein quantity overlooks a critical aspect of renal nutrition. While total protein intake is important, the source and composition of that protein significantly impact its effectiveness and potential for adverse effects. This approach is a failure to apply best practices as outlined in current literature and guidelines, which highlight the importance of high biological value proteins. Ethically, it represents a missed opportunity to optimize patient outcomes by not leveraging the benefits of specific amino acid profiles. A third incorrect approach that applies a blanket recommendation for high protein intake to all patients with kidney disease, regardless of stage or treatment, is a significant regulatory and ethical failure. This directly contradicts established guidelines that recommend protein restriction in earlier stages of CKD to slow progression and emphasize higher protein intake for patients on dialysis or post-transplant to combat catabolism and support nutritional status. Such an approach could lead to detrimental consequences, including accelerated kidney function decline in pre-dialysis patients and inadequate nutritional support in those on dialysis. The professional decision-making process for similar situations should involve a systematic assessment of the patient's kidney disease stage, eGFR, treatment modality, pre-dialysis, hemodialysis, peritoneal dialysis, transplant, nutritional status, including assessment for PEW and other comorbidities. This assessment should then be used to inform an individualized protein prescription, considering both quantity and quality, in accordance with current NKF-KDOQI and ISNM guidelines. Regular reassessment and adjustment of the protein prescription based on the patient's response and evolving clinical status are also critical components of best practice. Question 20. Operational review demonstrates a patient with stage 4 chronic kidney disease, CKD, presenting with a constellation of endocrine and metabolic complications including elevated parathyroid hormone (PTH) levels, evidence of renal osteodystrophy on recent bone scan, a hemoglobin of 10.5 g/dl, a history of cardiovascular events, and laboratory findings suggestive of insulin resistance and dyslipidemia. The renal dietitian is tasked with developing an initial nutrition intervention strategy. Which of the following approaches best aligns with current best practices for managing these interconnected complications? Option A. Recommend a high-potassium diet to counteract potential electrolyte imbalances and improve overall metabolic function, given the patient's CKD. Option B. Focus exclusively on increasing dietary protein intake to support muscle mass and address the anemia, as protein is a primary concern in CKD management. Option C. Implement a low-phosphorus diet without further assessment, as this is a universal recommendation for all CKD patients with mineral and bone disorders. Option D. Prioritize a comprehensive nutritional assessment to identify specific nutrient deficiencies and excesses contributing to the patient's endocrine and metabolic derangements, and collaborate with the nephrologist to develop a multidisciplinary plan addressing mineral and bone disorders, anemia, and cardiovascular risk factors. The correct answer is D. Prioritize a comprehensive nutritional assessment to identify specific nutrient deficiencies and excesses contributing to the patient's endocrine and metabolic derangements, and collaborate with the nephrologist to develop a multidisciplinary plan addressing mineral and bone disorders, anemia, and cardiovascular risk factors. Explanation. This scenario presents a common challenge in renal nutrition practice: managing multiple, interconnected endocrine and metabolic complications of chronic kidney disease, CKD, within a complex patient. The professional challenge lies in prioritizing interventions and coordinating care effectively, as these complications often coexist and influence each other. For instance, secondary hyperparathyroidism and renal osteodystrophy are directly linked to mineral and bone disorders, while anemia, cardiovascular disease, insulin resistance, and dyslipidemia are also prevalent and can be exacerbated by or contribute to the progression of CKD. The CSR specialist must navigate these complexities, ensuring interventions are evidence-based, patient-centered, and aligned with current best practices and regulatory guidelines. The correct approach represents best professional practice because it prioritizes a comprehensive, individualized assessment and a multidisciplinary team strategy. This aligns with the ethical obligation to provide patient-centered care and the regulatory expectation for evidence-based practice. By focusing on a thorough evaluation of the patient's current status, including laboratory values, clinical presentation, and dietary intake, the specialist can identify the most pressing issues and develop a tailored plan. Collaboration with the nephrologist and other healthcare professionals is crucial for optimizing treatment outcomes, as it ensures a holistic approach that addresses all facets of the patient's complex condition. This integrated approach minimizes the risk of conflicting advice and maximizes the potential for positive patient outcomes, adhering to the principles of quality patient care mandated by professional standards. An incorrect approach that focuses solely on one complication, without considering its interplay with others, fails to meet the standard of comprehensive care. For example, addressing only anemia without assessing or managing mineral and bone disorders or cardiovascular risk factors would be a significant professional failing. This could lead to suboptimal treatment, potential harm to the patient, and a violation of the duty of care. Similarly, implementing a dietary plan based on outdated guidelines or without considering the patient's specific stage of CKD and comorbidities would be ethically and regulatorily problematic, as it deviates from evidence-based practice and patient-specific needs. Relying solely on medication adjustments without nutritional assessment and intervention also represents a failure to utilize the full scope of the renal dietitian's expertise and a potential breach of professional responsibility. Professional decision-making in such complex cases requires a systematic process. First, conduct a thorough patient assessment, gathering all relevant clinical, laboratory, and dietary data. Second, identify and prioritize the most critical endocrine and metabolic complications based on their severity and potential impact on patient health. Third, consult with the nephrologist and other members of the healthcare team to develop a collaborative, individualized care plan. Fourth, implement evidence-based nutrition interventions, monitoring their effectiveness and making adjustments as needed. Finally, continuously educate the patient about their condition and the rationale behind the treatment plan, empowering them to participate actively in their care. This structured approach ensures that all aspects of the patient's health are considered, leading to the most effective and ethical management of their complex CKD-related complications.